Then we have the initial assessments. These are face-to-face interactions that have to last at least a minimum of 45 minutes in order to bill for those. I'll repeat again, they can be provided during pre-admission or they can be provided after admission. An assessment is a procedure while pre-admission is just screening status. These terms are not interchangeable. OMH allows up to 3 initial assessments during an episode of service. So that's while the person is enrolled in your clinic. That's not 3 assessments per year. Some people think it's 3 assessments every 365 days. If we think about this clinically, if someone's already enrolled in your clinic and you've been treating them for a year, when a new year comes around, there's no reason you would need to do another round of assessments. You're already very familiar with that person. So that's why that is, in fact, a misconception there. So there's 2 types of assessments. There's a 90791 and there's a 90792, which is the initial assessment with medical services. Another thing to note here is that while OMH allows you to have 3 initial assessments, what I've heard from providers, and as you all know better than I do, that a lot of managed care plans won't pay for 3 assessments. Most commonly, they will pay for 1 90791 and 1 90792. Now, some plans may pay for 3, and this is where you need to kind of track and know these things and have some type of internal cheat sheets or whatever you can do to kind of maximize revenue by knowing which plan is covers which of your patients, consumers. So in 90792, this is the initial assessment with medical services. These services can only be performed by a psychiatrist, a physician, or a psychiatric nurse practitioner. You'd think because of that the code alone would pay you properly for that credential level, but it doesn't. You have to add a modifier to that code in order to be paid properly. So here's the modifiers, AF for psychiatrist, AG if it's a physician, and SA is for your psychiatric nurse practitioner. This sounds easy, but in 2015, when we looked at the claims, 52% of providers weren't adding this modifier to your 90792s. That's a 45% difference in what you're being paid. That's huge. Huge bags of money left on the floor. And when we say with medical services, this is just like a simple systems review, health screening. This is the stuff that your docs and psych nurse practitioners should be doing as a normal course of business when they're meeting a new individual. Here's a money tip. What I would recommend, now while you can do a 90791 and add the modifiers to that, to simplify things for your staff and for your billing, I strongly encourage you, whenever it's an MD or a psych nurse practitioner, instead of doing 90791, just always default them to the 90792 and then program your billing software to automatically add the modifier. This way, you're not missing a modifier, and in the cases where the managed care plans only want to pay for 1 90791 and 1 90792, you're making sure you're picking up that extra money from that 90792, especially with the modifier on there, because that's big bucks. So here we can see that adding this modifier for these different, service types, upstate, $66 more, downstate, $73, and counties, that's $92 for each of those assessments by adding the modifier. So just to further illustrate how much more money you can make off of these assessments, if you look at a psychotherapy, A 45-minute psychotherapy visit will pay $130. But if you're putting that in, this is just one example for one of the, I'm not sure if this is upstate or downstate. But if you do that initial assessment and you bill that 45 minutes as a 90791, now you're making like $33 more on that. And if it's a 907, if you do 45 minutes of the doc time and you're doing the add-on on that service, you're getting paid this amount, $195.63 versus $236. So that's an additional $40 that you can make by doing a 90792 over the 45 minutes of doc time without it. So I just mentioned the add-ons before, the 45 minutes with the add-on. So physician add-on codes. I go out and sometimes I'll meet with clinic providers and I'll review their claims ahead of time, and we look to see where they're adding modifiers, where they're not, whether they're using these add-on codes. So physician add-ons are ways that you can get paid. If you look here on these E&M codes here, the series of 99201, 99205, all of these codes are the same. And if you look over here, you're being paid the identical amount in each of these cases, $104, whether you're doing a psychotropic med treatment, whether you're doing a 30-minute assessment or a 45-minute assessment. If you are not using the psych assessment add-on codes, the 90833, if it's 30 minutes, and the 90836, if it's 45 minutes, again, you're leaving bags of money on the floor. For Medicaid, OMH intentionally, so in order to use the add-on codes, it means that your doc, in addition to providing the evaluation and management service, those E&M codes, it means they also spent time talking to the individual and providing psychotherapy. OMH intentionally wrote this definition of psychotherapy so broadly that pretty much any type of discussion that you're going to have with that individual is going to be covered under this psychotherapy definition. So there's no reason, as long as the doc is, it's like anything. Whenever you bill any code, you need to make sure you're documenting properly whatever it is that you're providing. So they just need to include in that note that in addition to having, done a medication review, they also spoke with the individual about their symptoms or how they were doing, or like I said, pretty much anything is covered under here. The thing I want to note is the rules for Medicare are not the same as the rules for Medicaid. So the state had the option to take and include the 30 minutes of psychotherapy time within the total time that is spent. So for Medicaid, and I don't know if there's any psychiatrists on here or not, but I know that they've all received training, and I've had different ones, discuss this with me, and I've had to explain, and I, went back and made sure with our counsel's office that this is 100% correct for Medicaid. It's the total time that you spend for a Medicaid visit. So that's inclusive of the time you spend doing that evaluation and management service. So for Medicaid, total time spent is 30 minutes, add your 90833. Total time spent is 45 minutes, add your 90836 and pick up that money. Medicare, it's different. Note that, know it, that under Medicare rules, the time for the E&M service is above and beyond the time that you spend for psychotherapy. So if the total time spent on a visit is 30 minutes and you use the 90833 for Medicare, that is going to be an overpayment. So basically, if you serve kids, you're lucky, you're not going to have a problem. If you have Medicare onlys and you have duals, you're going to have challenges. There's going to be decisions and things that you're going to have to do on the back end with your billing software and knowing how to submit these services, because it's not going to be the same across the board if you're seeing someone with Medicaid versus Medicare. One of the things that we're looking at offering a future CTAC offering based upon the feedback from folks is, if you, and I've heard this, if you have these types of issues with Medicare and duals, let CTAC know, and they'll dedicate a webinar or future offering in the fall on different strategies for how to address these issues. Here's a bag of money tip. If you have new patients, if your psychiatrists are seeing new patients, and so the new patient codes are the 99201 through 99205, it's highly likely, really likely, that the first time the doc, and this was a polling question, so maybe at the end we can find out what the results of this polling question was, but this was why it was asked, is what's the average length of time your docs are spending with someone the first time they meet with them. If they're spending 45 minutes on that initial appointment, rather than just putting it in as a regular E&M new patient code, code those as a 90792. More money. And run reports. You can run reports and look and see how often those codes, 99201 through 99205, are being used, and possibly you can also look at the length of time spent. So that's something you just want to, any of these strategies, you need to share them with your staff if they're not already on this webinar, and just kind of bring it to the forefront of their mind so they know. So this is just a quick review of how much more money you can make on this doc time. A lot of the money that's being left on the floor is on your doc time. Your docs are your most expensive staff by far and away, and yet they're the ones, due to the complexities of the billing design, that could possibly be bringing in less money for you than some of your clinicians, because if it's not done correctly with these add-on codes and the modifiers and things like that, it's very easy to miss money that you should be getting. So if we look here at this row with the psych assessment, with the 90836, so that 45 minutes of time, if you bill that as a regular 45-minute visit with the add-on versus a 90792 with a modifier, then this row here shows us how much extra money you could be making. Here is the 90792 if you're not adding the modifier, which again, 52% of people aren't adding the modifier. Here's how much money you're leaving. And then if you're just billing, if your docs are just billing those new patient codes and they could potentially be using the 90792 with a modifier, here's how much more money for each of those services you could be making for your clinic. Crisis intervention. I recently met with a provider, and I had looked at their claims for last year, and they had billed for one crisis intervention in all of 2015. Anybody who works with anyone with a mental illness is doing crisis intervention on a regular basis. We all know this. It pays for a 15-minute visit. It ranges from $56 to $79. You can do this for a maximum of 6 units per day, and these can also be done by phone. So when you're getting those crisis calls and somebody is about to be, evicted, or somebody needs to be picked up in the community, or they're decompensating, or you have a child who's in crisis at home or in school, and you're spending time on the phone, remind your staff or clinicians out there, make sure you're writing a progress note for that and submitting each of those 15 minutes that you're billing this crisis intervention brief. If you have walk-in services, some of you offer walk-in crisis services, again, make sure that you're billing for this crisis intervention. You can also, it can be provided off-site. Sometimes I hear of providers that are clinics that are asked to go out on adult protective calls or other calls to accompany folks to go into a situation, and there may be a crisis. If you're going outside of your clinic into the community, and this is for both children and adults, make sure you're using an off-site rate code and that you're billing for that crisis intervention. Anything provided in the community off-site pays an additional 50% on that rate. Remember to use it. And then these are the other, crisis intervention complex and crisis intervention per diem. Those are, you're less inclined to use those. Those are less common. Another reason to make sure that you're billing for crisis intervention, or another very underutilized service, is complex care management. I'm always hearing providers talk about how much time they spend on phone calls, and this time isn't reimbursable. They're not getting paid for it. Well, sometimes you might be able to be paid for it. If there was a crisis, pretty much whenever you have a crisis, the likelihood, there's a very strong likelihood that you're going to need to make some type of follow-up calls to somebody. In that crisis note who it is you need to make a follow-up call. If they went to the hospital, you need to make a follow-up call with the inpatient staff. If you need to follow up with the school, a parent, CR staff, whomever else might be involved with that person, and you need to make a phone call, make note that additional follow-up is needed, that you need to provide complex care management. The phone calls that are routine and day-to-day phone calls, you can't bill for those. But if there's something significant, someone comes in for a therapy appointment, there's something significant that could result in a change in community status, or it's some type of complex condition, like your docs need to make a call to the pharmacy, they're worried that there's some type of an interaction, any of those kinds of things, document the need, bill complex care management. This can be, it's now been increased, so it can be 14 days after the original service is provided, and it's now billable in 5-minute units up to a maximum of 4 units, and that's going to pay $14 to $19 for each of those 5-minute units. Because I work for the Division of Children and Families, I'll just quickly mention off-site services for children. If you have school-based satellite clinics. Now, off-site can be for any of the children's services, but I'd like to recommend it for satellite clinics, because a lot of times if you're school-based, your staff could be on summer break right now, or there's a lot of extra holidays and weekly breaks. And these are times when you have an opportunity to engage the family, go do a home visit. You're providing continuity of care over those breaks. Write it in the treatment plan. It needs to be documented. It's very easy to show that you need to provide, continuity of care. Do a home visit, and off-site services pay 50% higher. If the family is there and you do a home visit for an hour, that's a 90847. So that's not only just for children's services, but that can also be for adults. If you're spending 60 minutes doing psychotherapy and the family is present for more than half of that, or about 29 minutes, it might even be less than 29, I believe I was told it could even be like 15 minutes. The family is present during that time and it's a 60-minute visit. Use 90847. It pays a higher rate. It'll pay you about $60 more than a 45-minute psychotherapy visit. All right, here's our Show Me the Money quick tips. Look at your claims data, whatever type of reports you have. This is just a summary thing. Go through, look for the new patient codes I mentioned earlier. See if those can be switched to the 90792 with a modifier. Look at how many initial assessments are you doing per individual. Try to get at least one 90791 and one 90792 for each new person at your clinic. Are you using the add-on codes, the 90833 and 90836 for the 30 and 45-minute add-ons? How many crisis visits were done last year? See if that makes sense based on what you know, how the frequency of crises at your clinic. complex care management. Also, if your clinic or you have satellites that are open before 8 a.m. or after 6 p.m. or on the weekends, are you using the after hours modifier, the 99051? Whenever a service is provided in those hour ranges, you should have your billing software automatically add that so you get paid an enhanced rate. And if you have any bilingual staff or you're using a translation service, make sure you're using the U4 modifier. Again, it's extra money that you're entitled to. That can also be anyone who's an employee of your clinic. If you have a receptionist who's bilingual and comes into a session and provides translation services, it just can't be with family members who are translating. So that was a review of the basic revenue maximization strategies. And now that you picked up all the bags of money off the floor, what else can you do? Unfortunately, printing money is not an option, although we all wish it was. So let's look at some other things. Payer mix. You can see here if you have a 75%, we all know Medicaid is the highest payer. The higher your Medicaid mix, the better off you're going to be. So here, the average revenue with 3/4 Medicaid payer mix, and these are just average rates that are in here, gets you 117 for average CPT. If you happen to have more commercial insurance, you can see here that your rate is going, your average revenue is going down. If you have high Medicare, Medicare is a killer. If you're serving a lot of geriatrics, you're really going to need to pay attention and take advantage of every revenue maximization strategy you can. Make sure you know what your payer mix is, and you need to know how that impacts your bottom line. Changing your payer mix is not an easy thing to do, but there are sometimes things that you can do, and CTAC can help with that. Productivity. So this is like how many billable services are your staff providing? So we have normalized weighted productivity. I've kind of translated that down below. I'm sure people, as soon as you hear that phrase, the first time I heard it, your brain kind of just fuzzes over, and so you kind of wish it was like Facebook and maybe there's a translation button for what is normalized weighted productivity. But it's like a standardization where you convert the CPT units to a standard 45-minute unit of service just in order to kind of look at what productivity levels are. So in order to meet what are kind of viewed as the general benchmarks for productivity, what you want to have productivity rates of like around 1,100. Some have 1,000. You really would like to get higher than 1,100, but these are kind of like the ballpark benchmarks, we'll say. So if 55% of your total staff hours are billable, then you can hit these marks. And you can see the impact here on what's your standard work week even, because the less hours in your standard work week, kind of the more billable hours you're going to have, the higher percentage of billable hours you're going to have in order to meet some of your revenue targets. And this is 55% billable. And we can see here if you go to 45% billable. Now billable, that means you're collecting money. So you have to be, seeing folks, submitting the billing properly. If you have no-shows, even though your staff is there, that's not billable time. We see a significant drop in the productivity levels, and lots of times I see productivity levels for clinics that are under 1,000. So anything when you're hitting 3 digits, you definitely need to boost your productivity here. And it has, right here there was an approximate 13% decrease in revenue, and that'll vary depending on your payer mix as well. What else do we have? How about denial rates? Now, Dave Wozniak, who's one of the CTAC experts, tells me that you really want to have like a 1% denial rate. Do you know what your denial rate is? Here I've shown some So I've done a 2% here. So if you have a 2% denial rate, then your average revenue per CPT is going to be 121. Then if you go to an 8% denial rate, it's 113 per CPT. So depending on how many units of service you're providing, obviously, the more units, the higher your denial rate, the more money that you're losing that you shouldn't be. Know what your rate is, set goals for your denial rates, and track them. Don't assume that somebody else is doing this because they might not be. Do you get denials from managed care plans that don't seem right? I hear this all the time from clinic providers. Are certain plans beating you up more than other plans? I hear that frequently. We won't name names, but OMH can help you with this. I have been told by the managed care folks, because I reached out to them and said, I'm continually hearing from clinic providers that certain plans are really not playing well with others and are denying claims for reasons that seem a little bit unreasonable. I've been told if you write down this email address, send copies of your remittance issues to this email. Explain to them what the problem is you're having, who you're having it with, and they can follow up on these issues. They meet with the plans on a weekly basis. A lot of the things I just mentioned, in order to know where you stand on all those areas that we just covered, you need to have reports on these. Not all folks are into data analysis. I'm sure we have clinic directors on here, and you guys are, went to school for social work, and now you have to deal with all this fiscal stuff and how to interpret reports. You really need to know what your key indicators are, and you need to look at them regularly. Here's just some sample reports, but one of the areas where I think CTEC could be really helpful in the future, and let them know on the polling questions, give feedback. If what you need to know isn't covered in the polling questions, type it into the chat boxes at the end. But they're planning on doing an offering on these reports, so you need to know how to make them, how to interpret them, how to use them. So do all of these revenue maximization tips help? Here's just a survey that I did of providers that have received the in-person training. So as you can see on here, about a third of them, a little over a third, increased their revenue. This is their projected increase in revenue as a result of these tips. So everybody doesn't need all of them. Some folks were already doing some of them, but pretty much everyone has certainly benefited. There's been something in here that they weren't doing that they're now doing that did, in fact, increase their revenue. Across the board, everyone had a revenue increase. Others, a little more than a third with a 5 to 10% increase, and then we have just a little under a third if we combine the other two categories with a 10 to 20% increase. So these strategies definitely make a difference. You can go back and adjust claims for some of these. And what does this mean for the fiscal viability of providers? This is the original slide where we had 56% of folks who were distressed, or not distressed, 56% who were losing money, 44% healthy. If you can take the different tips that are here, in addition to like those productivity increases, all of these things, if you just increase your revenue by 15% on average for clinics, we're now looking at 65% of providers are now healthy, which is, it's so important. We need providers out there, working with folks. Hopefully you found this information helpful, and now we want to ask you a few more polling questions, and then we have some time here after that where I will do my best to answer any additional questions that you guys are typing in.
Thank you, Lisa. Yes, if folks could just take a minute or two to answer the couple of questions that we're putting up through the polling function. It really would, like Lisa has mentioned, really be critical to help us strategize on what offerings might be beneficial to folks moving forward into the fall of 2016. So we'll give about 30 seconds to a minute for you to answer these couple of quick questions, and then we'll move on to some of the questions that might have come through the chat function. Thank you. If you do have any other questions, please remember to use that chat function to ask them, or if there are items that kind of fall into any of the polling questions that maybe there isn't a category that you're looking for additional support on, please feel free to add that to the chat area as well. All right, well, thank you everybody for answering those polling questions. We appreciate it. What we'll do now is we'll turn it back over to Lisa to go through some of the questions that have been chatted in, and with the essence of time, we'll see how many of those we can get through, but it does look like we have about 15 minutes or so left to be able to address some of the questions that have come through.
Okay, so I am going to go through these questions and answer what I can, and I never want to give misinformation, so I'm sure there are questions in here that I probably do not have the answers to, and I don't have an OMH fiscal person here, so we will, anything I can't answer, we will answer and get back to you. Just to clarify, what is the CPT code for the pre-admission visits? The CPT codes are the same as whatever the CPT code is. It depends upon the service that you provided. So if it was crisis intervention, you use crisis intervention. If it was a initial assessment, you use a 90791. So there is no pre-admission. It just means screening status. It's not a visit. It's not a procedure. Okay, so just to clarify that. The code is the code depending on whatever the service was. It just means you get to bill for 3 of those visits before you have to admit the individual to the clinic. Health home presentations through CTAC, you guys will have to log in. CTAC and also the MCTAC website. And I think there's a slide after this to check out the new website. You can check there to see what other additional webinars are offered. They do all kinds of things on all kinds of topics, clinical topics, evidence-based practices, business practices, the new managed care services, all kinds of stuff. So you definitely want to make sure you're on their listservs. Is a 90832 allowed on the same day as a 99201 with the add-on 90833? Yes, because you're doing a psychotherapy for the 90832, I think off the top of my head is the 30-minute psychotherapy. Mm-hmm. And then the other service, the 99201, is the E&M for the doc service, and the 90833 is the psych add-on. So yes, you absolutely can do psychotherapy and doc visits in the same day. I think they go through the grouper, and there's a 10% discount maybe on the service, but yes, you can do that. If you're getting denied a denial on that second service, send a copy of the remittance with the managed care plan that you're having the issue with to the email that we had. Does each 15 minutes need to be documented separately if you spent 45 minutes in one shot on the crisis? I'm going to tell you that I'm not sure the answer on this, so Joyce, you could jot that down. I don't have a field office person will probably know that too. So we will get back to you guys on that. I'm not positive. I didn't believe off-site visits were billable. Can you say more? Off-site services are billable for children's services. For adults, you can only provide off-site off-site crisis services. And I'm going to put a little asterisk next to that because I know with the new adult behavioral health services, and so I work in the Division of Children and Families, so I'm not 100% up to speed on the new adult, like HARP services and HCBS services, but I'm talking strictly just for current clinic under 599 regs. It's 100% paid for through state funds currently. There's no federal match, but you can provide them for children off-site and then crisis only for adults off-site. All this stuff, I also strongly encourage you to go to the OMH website, and at the bottom there's a place where I'll say clinic guidance, and go to the 599 guidance documents. So all of clinics, the regulations that you follow are 599, so you'll hear that reference. So go, the regulations and the guidance documents are there to check these. Another one on the CPT code for pre-admission, so hopefully we covered that there's no CPT code for pre-admission, it's just a screening status. Oh, somehow I'm getting all these questions doubled. For walk-in crisis intervention, what is the diagnosis we use to bill if client is not admitted or a patient of the clinic? You can use diagnosis deferred. And under ICD-10, I'm not remembering the code off the top of my head, but there is a diagnosis deferred that you can use when folks are in for those pre-admission visits. If you don't have a diagnosis, you can do diagnosis deferred. I cannot guarantee you on that some plans might deny that and might require you. I know I've heard feedback that sometimes the plans get glitchy or difficult with what the diagnostic codes are, and those aren't something that, you know, they're required to pay government rates. If there's a coding issue, you kind of have to work with the plan to follow up to find out what their rules and limitations are there and work with them to make sure your claim submissions meet what they want. Our providers are not covering crisis and complex care management. We end up writing these visits off. I don't know why. I assume you mean plans aren't covering them. I don't know why that would be, and certainly crisis visits, that makes no sense. Send copies of those remittances, the denials that you're getting, email those in. The slides will end up being posted on the CTAC website. They'll be available, you know, you'll have to wait a day or two and then those will be posted.
Yeah, after the questions we can talk.
What's that?
After we're done with the questions, Lisa, we can walk them through where to go to get to the posting at the CTAC website.
Okay. Do you have any guidance regarding the use of health monitoring codes? Which clients are eligible? What must occur during the visit, documentation, etc.? You can go to the 599 guidance document on the health monitoring codes. In there, it will also tell you which staff are eligible to provide the different services. I'm looking here quickly. I'm pretty sure it's like an MD, RN, health monitoring. MD, psych nurse practitioner, RN, LPN, physician assistant are eligible staff to do health monitoring. Now, if you note your rates for the health monitoring services, they're really, really low. I don't recommend, the other day there was a provider who has a psychiatrist doing health monitoring. If there's any way to kind of include what the psychiatrist is doing under some other type of service, because the health monitoring, I think, pays like $39 or something for 15 minutes. Those rates for health monitoring are set by DOH, not OMH. So just kind of make note of what level staff and how much that staff, how much you're paying for that staff to spend that time with someone for some of those services. Are the modifiers only mandated to be acknowledged by Medicaid and Medicaid managed care plans? Are commercial products excluded? Any of the commercial stuff, I know nothing about what the commercial requirements are. You'll need to know each plan and what each plan covers and what their rules are. I can't speak to commercial products. All right, some folks weren't able to answer all the full questions. Sorry about that. Okay, someone asked, do you have any thoughts on health monitoring as a service in regards to the pros and cons for generating revenue? So I probably just kind of shared that already, that it really does not pay a lot, so you kind of have to balance the needs of folks, and sometimes if you really want to provide integrated services and integrated physical health services, you might want to even look at partnering with an Article 28 or another. This is kind of above and beyond, obviously, the scope of this conversation, but look at having another entity do that within their kind of world of regular business. The same as if you want to integrate and put, you know, clinicians or have a satellite in a pediatric practice or a doctor's practice. Will managed Medicaid companies pay for off-site visits or only straight Medicaid? Medicaid managed care plans are not, there's a different rate code that you use for the off-site services, so you'll need to look at your 599 guidance in order to make sure you're billing the right rate code. I know we're nearing the end here. Regarding crisis intervention, 15 minutes in person or on the phone. Question is, who is on the phone with a clinician? Does it have to be the patient? No, it does not have to be the patient. It could be a family member, it could be a parent, it could be the school. It does not have to be the patient who's calling you about the crisis. How does an organization go about setting up an on-site revenue maximization visit? I will let you know that those are not done by request, so please don't contact me to request them. Those are kind of done as the need. There's an identified need at a higher level, like often exec staff here will say there's a need somewhere. There's a fiscal review that identifies that a provider needs that. I know everyone would love to have them done, but since we're not able to go everywhere and provide them to everyone, that's the reason we're offering, you know, taking kind of that information and putting it in this format so we can share it on a larger scale. I'm hearing higher productivity levels at some clinics. Do you know what is the average level at successful clinics? So that ballpark, again, you want to be hitting like at least 1,100. It could be 1,200. You know, there's different factors here. Indicate also, if that's something you're interested in, indicate in the polls. You can also, if there's specific things that weren't covered in the polls that you would like to see or get additional information and support on, type it in these chat boxes and shoot that off to CTAC and they'll let you know. On-site visits. I have no idea what you mean. I don't know if you meant to put off-site visits. That I talked about on-site visits.
She made you go, the on-site visits.
Oh, me going and doing on-site visits. Oh, yeah. Right, we just covered that. When adding modifiers, it increases our reimbursements right? Not discounts it. Yes, they should increase your reimbursement except when multiple services are provided on the same day, and then they go through the grouper, and then there's some type of a discount that's put in there. Right, so the use of U5, that's if you provide a 20-minute psychotherapy versus a 30-minute, a reduced time, you can use the U5 modifier. Do I recommend the use of collection agencies? Oh, honestly, I have no, I mean, I'm not sure how you're asking that, if it's for copays or if it's against managed care. I'm not sure. I would need more information to answer that, but it's probably also kind of outside the scope of my world. Is there any guidance for the use of E&M and its elements? That's also, the E&M codes, that's something the docs should be skilled in. I'm going to turn this back over to Jason because I know, so we here do not offer, you know, concrete guidance on how the docs should be using the E&M codes. Also note for Medicaid, the increased complexity that you indicate in those E&M codes, you don't make any more money if it's a more complex case. So Jason, I'm going to turn this over to you to close us out.
Great. Thank you, Lisa. We really appreciate the time of walking everybody through the slides and spending some extra time working through the chat questions that came through. If we could just advance the slide deck one more slide for us, if you don't mind, Lisa.
I did.
Oh, you did? Okay. Okay, great. So we had mentioned a few times that there's a new CTEC website. So in about 48 hours or so, we'll be able to post the recorded version of this webinar. And if folks go to that new CTEC website, they'll be able to go to the tools bar over to the right-hand side, and if they scroll all the way down from the toolbar, there'll be an area called Search Our Training and Tools, and that's where they'll be able to find any recorded and posted presentations, this being one of them in a few days. So we want to thank everyone for participating today, for answering the polling questions. We did hear, as you mentioned, that maybe a little bit more time would have been valuable, but we wanted to make sure we were able to get through all the content as well as have some time for questions. So thanks again for everybody for participating and providing feedback on the webinar with the polling questions. And thank you very much.